Hi guys. First of all, I am very sorry that this happened. That causing a lot of confusion. I just want you to understand that this is some really unfortunate circumstance that no one could expect. I really didn't expect that we would have this weather condition in October. So hopefully we can get through this through recording. I'm gonna do my best to go through them as much in depth as possible, and then luckily we're gonna have our case conference together on Thursday, so we can spend some of the time to answer your questions and then also for me to highlight some key points. The good thing is there are not that many drugs for thyroid and adrenal gland disorders, so nothing like hypertension or diabetes that we have a lot of drugs to remember. So really getting the good grasp of the overall global concept, and then really knowing which drug to be used and then what to counsel our patients for those drugs is really the key. So uh, the objectives, you can kind of go through them on your own, but basically to try to find out how our patients will present when they have thyroid or adrenal gland disorder, really what lab values we use to monitor these patients, and what is the goal of therapy. Also, really for adrenal gland disorder, we're going to go through corticosteroids, some differences between all of the commercially available corticosteroids, and then how to educate our patients. So the first page for the first diagram we have, it's for regulation of thyroid hormone and secretion. So I'm not gonna go really too much into the pharmacology of it, but really knowing that this is regulated by hypothalamus and anterior pituitary. So hypothalamus will secrete thyrotropin releasing hormone that stimulate anterior pituitary to make TSH, thyroid stimulating hormone, or also known as thyrotropin, that finally signals thyroid gland to make thyroid hormones. So there are two forms, T3 and T4. So T3 is known as triiodothyronine, and then T4 is thyroxine. So T3 is the more potent active form of thyroid hormone, whereas T4 is considered prohormone that is eventually to be converted to T3. So T4, 100% of T4 is made by thyroid gland, whereas only 20% of T3 is made by thyroid, as you can see on this diagram, whereas 80%, the remainder of T3s, will be eventually converted from T4 to T3 in periphery. So peripheral conversion of T4 to T3 via deiodination of T4. This is for really accounting for the majority of T3 we have in our body. So when we have enough of T3 and T4 in our system, there is negative feedback that goes back to pituitary and hypothalamus, so that we don't have enough hormones that signals thyroid gland too. So this is how our thyroid hormones are regulated. So know that T3 is more potent form over T4, and then majority of T3 is produced by peripheral conversion from T4 to T3. All right, so thyroid function test results. So we use all these tests, but the main thing we use is TSH, again, thyroid stimulating hormone. So you don't have to know all these normal values, you can always look it up, but I want you to remember the TSH normal values. So 0.4 to 4 micro international unit per liter. So depending on what reference you are looking at, some of them will say a little bit slightly different reference range, kind of like any other lab values. So usually 3.5 to zero point 0.4, or some reference will even say zero point 0.5 to 4 to 5. So that's roughly the normal range. So whenever we do TSH and the TSH is decreased, that indicates primary hyperthyroidism, meaning that there is less TSH because there is too much T3 and T4 that are being produced. So the negative feedback goes back to hypothalamus and pituitary producing less TSH, trying to combat the high amount of T3 and T4. Whereas when TSH is elevated, that really indicates hypothyroidism in primary condition. So there are going to be a lot more elevated TSH trying to combat the reduced amount of T3 and T4. So when, depending on the TSH results, now you have to order total T4 and free T4 to see where they are. So when TSH is low, but T4 is high, that indicates hyperthyroidism, whereas TSH is elevated, and then now T4 on the other hand is low, that shows that patient has hypothyroidism. So have a concept, where how TSH and T4 they kind of or are opposite of each other. And one thing to note here is T4 is really tightly bound to protein, so about 99.97%. So almost everything is bound tightly, that makes their half-life very long. So their half-life is about 7 days compared to T3. The majority of T3 is also bound to protein, but it's not as tightly bound to it compared to T4. So that's why their half-life is much shorter, about 1.5 days. So this, we will come back to this because it leads to the duration of action and how often we give these drugs depending on their half-life. All right, so we're gonna go with hypothyroidism first. So I'm gonna break up my recording to hypothyroidism, hyperthyroidism, and adrenal gland disorder. So there are gonna be 3 recordings total. So you guys can look into guidelines when you have chance. They're quite long, so there are 2 major ones. 2014 American Thyroid Association guideline. They're about like 80 pages, and then there is a little bit older one that is collaboration between American Association of Clinical Endocrinologists and American Thyroid Association. So they are pretty similar, but then they talk about a little bit of different topics in their guidelines. And American Academy of Family Physician, it is not like a standard guideline, but they are much shorter and they summarize some points and treatment algorithm in really nice manner. So I use some of their tables and some of their algorithm in my lecture. All right, so quickly background, it is hypothyroidism is very common condition, about 1 in 300 persons. Untreated hypothyroidism can contribute to many different function of our body and many organ system, and then much more common in female than males, about 3 to 4 times more common in female patients. And autoimmune thyroid disease is the most common etiology in the US. So autoimmune, basically Hashimoto's disease, is the most common form of hypothyroidism, and this is what you're going to see the most in your practice. So primary hypothyroidism is basically when there is something wrong with the thyroid gland itself. It's not making enough thyroid hormones, whereas secondary hypothyroidism is caused by either pituitary or hypothalamus level. So because there's something wrong with those pituitary and hypothalamus not producing enough stimulating hormones that leads to reduced production of thyroid hormones. So the lab values we just went over, that was mainly for primary thyroid disease. When patients have secondary cause, their TSH will be low, that is leading to reduced production of hypothyroid thyroid hormones. So you need to know the difference between these. All right, so clinical presentation. So the In the adults, the clinical presentations is very non-specific, and there are going to be a lot of different um, presentation. But in children, it'll be mainly presented as growth or intellectual retardation because it really affects the growth of children. So really the most common symptoms are dry skin, hair thinning loss, so brittle hair, cold intolerance, weight gain, constipation, weakness. So our metabolism will be very slow when patients don't have enough thyroid hormones. So anything to do with slow metabolism, that's gonna be what you're gonna see in the patient presentation and symptoms. So depression, fatigue, exercise intolerance, um, also infertility in childbearing age women is very common as well. Again, most common signs are coarse skin, hair, cold, dry skin, bradycardia, hypertension, especially in diastolic, slow speech. Galactorrhea is when a woman has milk production when they're not breastfeeding. So that can happen. And then some laboratory results that you should be aware of is actually elevated lipid panel. So this is not something you are going to treat, but when patient's thyroid level comes back to normal, this should be resolved. And patient can have anemia, normocytic anemia, or proteinuria as well. So if it's a primary cause, their TSH will be elevated, trying to stimulate their thyroid gland. Again, when it's secondary, they're going to be either decreased TSH or there can be normal TSH. And then either primary or secondary cause, free or total T4 and T3 concentration should be low. Some other tests that can be done is when patient has either thyroid peroxidase antibodies or any other thyroid globulin antibodies, it's more likely to have autoimmune hypothyroidism. And I realized that there was typo. So radioactive iodine uptake is basically measuring how much iodine the thyroid gland takes up. So it shows the production of thyroid hormones and the distribution of the hypothyroidism by giving this radioactive iodine and see how they get distributed. So when they have low radioactive iodine uptake, that shows hypothyroidism. All right, so moving to the evaluation of for suspected hypothyroidism. So the first thing usually what we do is when patients present with signs or symptoms of hypothyroidism, when you suspect that, then we're going to measure serum TSH. So when patient serum TSH is high, that's what indicates may indicate primary hypothyroidism. So then you have to do free T4 really to see whether it's low or high. So when it is low, that's what we can confirm patient has primary hypothyroidism. Again, TSH high, above the normal range, and then when free T4 is low, that confirms primary hypothyroidism. When patient has high TSH, but their T4 is in normal range, that is considered subclinical hypothyroidism, meaning that they don't have hypothyroidism yet, but then they're kind of in that, it's almost kind of like pre-diabetes, the patient may develop into hypothyroidism. So it was a little bit controversial whether we should treat these patients or not, but when patient present with subclinical hypothyroidism, we can consider initiating therapy with levothyroxine if their TSH is high, like over 10, or they have increased thyroid peroxidase antibody titer, meaning that they are likely to have autoimmune Hashimoto's disease. So they are likely to progress into active clinical hypothyroidism, or when patient desires pregnancy, because during pregnancy, woman requires more thyroid hormones, so it is better to initiate therapy sooner than later. And then patient actually has symptoms. So even if their T4 level is within normal range now, if patient has symptoms, they're likely to develop clinical hypothyroidism sooner. And if patient has high TSH and it is above normal range, it can be some other issues that patient has to be referred really to identify the real cause of these abnormal lab values. All right. I did not realize that this will happen. Let me see if I can rotate. All right, good. So, like I said, there are not that many drugs really for thyroid disorder. So there are like just few for hypothyroidism and just 2 drugs for hyper as well. So there are not that many drugs we need to remember. That's a good part. So thyroid USP, usually you guys are know the brand name Armored Thyroid, which is the most common form that is in the market right now. So basically, this is desiccated thyroid extract. We used to have pork, beef, and sheep extract, but now most all of them are from porcine, so basically from pork. So this is animal source of thyroid hormones. So even though some patients may consider this more natural form because it's naturally occurring thyroid hormone, but remember this is from animal source. So it is really unpredictable. The ratio between T4 and T3 they kind of vary, and there are way more T3 content in this form compared to how much we have in our natural human thyroid hormone. So you may get way too much T3, leading to really high elevation of T3 levels, which can lead to toxic symptoms. So it's really not recommended. So I'll talk about it a little bit more in depth later in other notes. But their dosing comes in 1 grain. So 1 grain equals to 60 milligrams. And then 1 grain of is about 1 grain is about 60 to 100 microgram of T4. So you need to really kind of understand that the equivalent, what is equivalent. So again, it kind of varies. So it's really hard to convert from one to the other, and we have to make sure to check patient's TSH when this change happens. So really what you need to remember is it is animal source, it has unpredictable ratio and much higher T3, not preferred. So L-thyroxine or synthetic T4, mainly known as levothyroxine, is a main, really the drug of choice for treating hypothyroidism. So it comes in many different brands and generics now, and there are a lot of dosage that are available, which makes it really easy for us to titrate the dose up. So it is stable, predictable potency, well absorbed. It is more potent than desiccated thyroid. And there can be some variable absorption between products. So there are some AB rated generics available. However, the problem with levothyroxine is it is considered narrow therapeutic index drug, meaning the small changes can really have a lot of clinical impact, causing more adverse events. So pharmacy is really encouraged to keep with the same brand or generic, whatever patient's getting. It is the best to really keep the same formulation. However, there are times that it has to be changed to another brand or another generic version. So when that happens, we need to make sure to notify the patient. And also, it is really the best to check TSH within 6 to 8 weeks after the dose change, just to ensure the patient has stable TSH. Again, levothyroxine's half-life is about 7 days. So because of this long half-life, we can give the dose daily, once daily. Whereas liothyronine is basically a synthetic version of T3. So remember that this one has really short half-life, about 1.5 days, and this requires multiple daily dosing, about 3 times daily. And each dose that cause peaks and troughs, which make it pretty challenging to really adjust the dosing, because taking TSH when there's peaks and troughs cause a lot of variation in TSH. So it is recommended to take both TSH the first thing in the morning, the trough TSH, and also a peak from 2 hours after the dose. The last one is Liotrix, which is a synthetic combination version of T4 and T3 in 4:1 ratio. So because it is synthetic version, it is much more stable and predictable compared to thyroid USP. However, it just doesn't have any rationale for use, because like I said, T4 is going to be converted peripherally to T3. So there is really a lack of evidence that we need to give both T4 and T3 for therapy. Also, the ratio is much higher in than what we really have in our natural human body. So it's about 14:1 ratio of T4 to T3. So 4:1 ratio will give way too much T3, kind of similar to desiccated thyroid hormones. So really know that L-thyronine or levothyroxine is a drug of choice, and the other ones we just don't have enough evidence to support that they are going to be better or even as effective as levothyroxine. All right, so let's go over some questions and answers from American Thyroid Association guidelines. So first question is, levothyroxine monotherapy considered to be the standard of care? And yes, levothyroxine is recommended as a preparation of choice for treatment due to its efficacy. All right, so what are the clinical and biochemical goals for levothyroxine replacement therapy? It is to provide resolution of the patient's symptoms and signs, achieve normalization of serum thyrotropin. So thyrotropin is TSH, to avoid overtreatment. All right, next question. Are there situations in which therapy with levothyroxine dissolved in glycerin and supplied in gelatin capsule may have advantage over standard levothyroxine? So standard levothyroxine comes in tablets, but there is a capsule form that is dissolved in glycerin, and there is some data suggesting that the capsule form will be better absorbed, but there is no long-term data that supports that. So at this point, we just recommend, the guidelines recommend the standard tablet form of levothyroxine as a drug of choice. All right, so what factors determine the levothyroxine dose required by hypothyroid patients? So we need to base on patient's weight, lean body mass, and pregnancy. So we're going to go over the dosing in the next page. What is the best approach initiating thyroid and adjusting the therapy? So therapy should be initiated as an initial full replacement or partial replacement, and then check TSH in 4 to 6 weeks. So again, we're going to go over the dosing, how to initiate and how to adjust in the next page. All right, next one is there thyroid extracts better than levothyroxine alone? So basically talking about desiccated thyroid. And the answer is there is not enough data supporting that. So really recommending levothyroxine therapy alone. And the following question is, what about combination treatment with levothyroxine and liothyronine? So basically giving synthetic T3 and T4 together, and same thing, there is no strong data. So we just don't have a recommendation. So the guidelines recommend against the routine use of combination treatment. And again, when we give T4, it will be converted to T3 in periphery. So most of the case, there is no reason to give T3 and T4 together. What about the patient who are taking levothyroxine, but they are not feeling well while taking levothyroxine? So is combination treatment better? Same thing, we just don't have enough data. And there's some data suggesting that maybe some polymorphism or some genetic change that may lead to less conversion from T4 to T3. So maybe those patients will require T3 to really have full thyroid replacement. But again, we don't have enough data really to support, and we don't have any routine lab to identify those patients who have genetic dysfunction or polymorphism. So at this point, the guideline does not recommend the routine use of combination therapy. And the final question is the therapy with T3 alone better? And again, there is, so basically T3, the synthetic one, liothyronine or cytomel, they have to be given 3 times daily, and then there is really no long-term data that this is really something beneficial. So the guidelines do not recommend the use of T3 alone, and actually it can cause more harm than the benefit of giving just T3. All right, so let's go into the dosing. So the guidelines is for normal younger adult patients, the full replacement is recommended, especially when their TSH is highly elevated. So over 10 is usually what we indicate, highly elevated TSH. So the dosage can be 1.6 microgram per kilo per day. There's some conflicting data whether we should use ideal body weight versus actual body weight. So we're gonna just use actual body weight in our class, but some suggest that for obese patient, probably ideal body weight will be more accurate form. But for our class, we're gonna use just actual body weight to calculate it. So older patients, rather than doing full replacement, we want to start at low dose, so 50 microgram as a starting dose, and increase slowly every 6 to 8 weeks. But when patients have coronary heart disease, especially ischemic heart disease, we want to really start at even lower dose, so 12.5 to 25 microgram, and increase as slower titration, and then also monitor angina. So giving too much of thyroid hormone at once can really trigger some cardiac adverse reactions. So it can cause atrial fibrillation, can cause even heart failure and MI. So we have to be very careful starting at low dose and titrate slowly. For pregnant patients, they require more thyroid hormone, as I mentioned already. So strategy can be increased to 9 doses weekly. So 1 extra dose on 2 days of the week in the beginning of the pregnancy, and then of course we'll have to monitor TSH again and adjust based on the need. And patient with subclinical hypothyroidism. So when patients basically present with elevated TSH, but their T4 is normal, so I mentioned that that's considered patients with subclinical hypothyroidism. So when patients' TSH is lower end, less than 10, we can start at 50 microgram daily and increase by 25. But when patient present with high TSH, then we can just do the full replacement from the beginning. All right, so what do we need to monitor? So the goal TSH is 0.5 to 3.5, and then we check TSH every 6 to 8 weeks or 4 to 6 weeks. So again, to really get to the steady state, we need 4 to 5 half-lives, right? And T4's half-life is 7 days. So it'll take at least 4 weeks to really reach steady state to have accurate reading of TSH. So either 4 to 6 or 6 to 8 weeks is okay. So depending on the reference you're looking at, there are going to be some discrepancy, but usually I recommend 6 weeks, kind of in the middle, to wait to get the TSH. And once patient is stabilized, then we can monitor 3 to 6 months during the first year, and after that, after the first year, when their patient's TSH is stable, then we can check TSH annually from there on. All right, so we need to be careful and educate our patients that there are going to be some drug-food interactions with levothyroxine. So any drugs that decrease T4 absorption by binding to levothyroxine, we need to educate our patients to take levothyroxine at least either 1 to 2 hours before or 4 to 6 hours after taking the drugs. So the main thing: calcium, magnesium, zinc, aluminum, iron, and any multivitamin that contains any of these vitamins and minerals, they have to be taken either 1 to 2 hours after taking levothyroxine or 4 to 6 hours before taking it. And also cholestyramines, sucralfate, they can also bind to levothyroxine and delay the absorption, so they have to be also to follow the same rule. Any drugs that increase T4 metabolism, so basically all CYP450 inducers, so rifampin, phenytoin, phenobarbital, all of these, actually also sertraline and quetiapine, they can be also included. So these are known to increase T4 metabolism, so they have to be really carefully dosed. And warfarin and digoxin can also have some pharmacodynamic interactions. And then food also can impair T4 absorption, so it is really advised to take it on empty stomach. So really the key of taking levothyroxine is to take the drug regularly and consistently. So take it every day, adhere to the drug therapy regimen, but then take it in consistent manner. So you're going to learn this in warfarin dosing later, but there are going to be drug interaction, food interactions, but really if you're being consistent with how you take it, with regards to other drugs you're taking or other food, the food intake, if it's consistent, we can adjust the dose around your routine. However, if the patients keep changing when they take it, when they take other drugs that may interact with levothyroxine, that's when it becomes a problem. So really poor adherence or interaction with food is the most common cause of persistently elevated TSH level. So when you see patients who are TSHs keep elevated or it fluctuate a lot, really the first thing to check is the patient being adherent to the drug? Is the patient taking it every day? Or what about the food? It is really something you need to check first. So we actually had one patient refer to us last week that the patient's TSH has been fluctuating a lot. And when you look at the medication list of the patient, there really was not any other medication that was on the list that would interact with the patient with the levothyroxine. So we call the patient, as if patient is on any multivitamins or anything like calcium, iron, aluminum, magnesium. So those can be taken over the counter, so we need to make sure to check that. And this patient actually was drinking coffee um, every morning with levothyroxine, and coffee has to be avoided as well. So anything other than water is recommended to be avoided, because coffee can also bind to levothyroxine and really delay the absorption. So we advise a patient to actually stop drinking coffee with levothyroxine, wait at least half an hour after taking the drug. So we'll have to check TSH now in another 4 to 6 weeks to see how his TSH is after stop drinking coffee at the same time with levothyroxine. And checking with refill history with the pharmacy is another strategy to monitor patients' adherence and check patients' medication list for drugs that can affect TSH level. So the best thing to do is take levothyroxine on empty stomach 30 to 60 minutes before breakfast, and or other meds or even coffee. So 60 minutes is much better compared to 30 minutes, but giving some leeway that patient can take about 30 to 60 minutes prior to breakfast. This can become a problem when patient is also taking bisphosphonates. So bisphosphonate is the first line therapy for osteoporosis. So you're gonna probably learn this in the spring semester when you learn women's health. So I'm not gonna go too much in depth with that. But basically, bisphosphonates has to be also taken on empty stomach at least half an hour before breakfast. And bisphosphonate will have to be taken first before levothyroxine, because levothyroxine has pretty good oral absorption rate, about 80%, whereas bisphosphonate oral absorption rate is only about 1%. So we have to really ensure that bisphosphonate gets absorbed as much as possible. So there is no theoretical drug interaction between bisphosphonate and levothyroxine, so maybe they can be taken together, but we really want to be cautious and ensure that bisphosphonate is really taken on empty stomach. So some strategies can be usually bisphosphonates are taken once weekly, but you can consider even switch to monthly or even injectable one that's given once a year. So there is as much of a less interaction or confusion in how to take it. Or sometimes another strategy can be take levothyroxine just for 6 days and skip the day when you have to take bisphosphonate. Remember, levothyroxine has really long half-life, so this can be okay strategy. And another thing we can try is delayed release risedronate, actonel, which is one kind of bisphosphonate, actually can be taken regardless of food, so it can be taken after breakfast. So maybe using that will help so the patient can be take levothyroxine first thing in the morning, and then take risedronate after breakfast. So when you notice patient taking bisphosphonates, you have to really counsel patient and see how patient's doing and come up with a strategy that patient can really be adherent to the regimen and then be consistent in a way how they take the drugs. So morning administration is not always convenient for our patients, depending on their routine, how busy they are in the morning getting ready to go to work and stuff. So another strategy can be taking it in the evening. So you can actually tell patient to take levothyroxine in the evening, but it will have to be 4 hours after the last meal of the day. So to ensure that it's still empty stomach. And actually some studies shown that doing this regimen instead of morning, half an hour before breakfast was better. So so taking it in the evening 4 hours after meal was better than taking 30 minutes before breakfast. So of course 60 minutes before breakfast is the best way to do it. However, when patient is not waiting enough to eat their breakfast, probably this taking it in the evening at bedtime would be better strategy. And then some theory behind that is so acidic stomach environment is what we desire for better absorption of levothyroxine. And then that's why gastric acidity is actually lower. So there is a higher acidity. So uh, and then lower motility at night. So that can be explained why this may be a better choice. And I actually forgot to mention in the on the note I realized that PPIs and any H2 blockers. So those NIAC drugs are actually something to that can also interfere with levothyroxine absorption because, like I said, we need a acidic environment in our stomach to better absorb our levothyroxine. So when patients taking PPIs or H2 blockers that makes stomach basic, that can really interfere with the levothyroxine absorption. So when patient is uh, start to take those medications, we have to make sure to check TSH, and we may have to increase the dose based on patient's TSH. And another strategy is we can maybe consider doing levothyroxine once weekly, but this is not something that is really routinely done. But this is a possibility given the long half-life of T4. And again, separate levothyroxine by 4 hours from medication that inhibits its absorption. So I'm gonna go back here and then write that uh, PPIs and H. You got everything. And I'm gonna stress this again in on Thursday case conference. All right. So what if the patient doesn't respond well to just levothyroxine alone? So almost 15% of patients will continue to have fatigue and other hypothyroid symptoms. So they're gonna come back and complain, oh, this is not working for me. So it is important to rule out any other possible cause, such as underlying depression, anxiety, anemia, or other autoimmune disorders. So a patient with Hashimoto disease, they tend to have other autoimmune disease as well. So it is important to check that. And then also we need to educate our patients that it takes about 3 to 6 months really to see the full benefit. Even though their TSH and T4 level will normalize in 6 to 8 weeks, it really takes at least 3 to 6 months to really get the full benefit. So we need to really communicate that with the patients. So, like I said, adding synthetic T3, liothyronine to levothyroxine can be an option, but again, it is very controversial, and then there is just not enough good data or evidence that this is really beneficial, and that it can actually increase CB risk if you end up giving too much of T3. So liothyronine to levothyroxine ratio, if we do this combination therapy, should be 1:14 ratio. So that's a physiologic ratio our natural human body has. All right, so finally, again, going back to the point, desiccated thyroid versus synthetic thyroid supplementation. I put it here because this is one of the questions I hear a lot from our providers and also patients, that they think that desiccated thyroid, armor thyroid, is better because it is a natural thyroid, so they think that it can be safer and better than synthetic levothyroxine. So really, it is animal source. So it has more than just T3 and T4, and it can have more other molecules that this animal thyroid gland secretes. And there is no proof that these substances is needed for humans. So those some molecules that are going to be contained in this desiccated thyroid is something that we don't have. So that is can be one problem. And then, like I said it already, the ratio between T3 and T4 is almost 4 times higher than human has. So you can get just way too much supraphysiologic T3 level, which can cause some adverse events. So at this time, there is no proof that desiccated thyroid is better than synthetic levothyroxine alone. And then also, again, because it's animal source, it can cause some allergic or sensitive reaction. And so current guidelines does not support the use of desiccated thyroid, and they say it should be really avoided in general. All right, so last point is myxedema coma. It is really extremely rare, but extremely severe manifestation of hypothyroidism. So this is medical emergency. So it occurs mostly in older women with history of primary hypothyroidism. So clinical presentation is basically mental status change is a major thing when for those patients who have hypothyroidism, and it can develop to even psychosis. And hypothermia, hyponatremia, hypoventilation, and bradycardia is the clinical sign. So this really is a medical emergency. The patient has to be treated in ICU to really get ventilatory, electrolyte, and hemodynamic support, treated with corticosteroids and IV levothyroxine. So I'm not going to go into the details of the treatment, but basically when patient has myxedema coma, it is a medical emergency. The patient has to be admitted and then treated in ICU setting. All right, so that's all I have for hypothyroidism. I will also record the other lectures for hyperthyroidism and adrenal gland disorder. So thanks for listening, and then I will answer any question you may have on Thursday at the case conference. Thanks.